Welcome everybody to our third Immunization Economics Special Interest Group webinar. Today we have Dr. Brian Patenaude as our guest. He's an assistant professor at Johns Hopkins Bloomberg School of Public Health and director of economics and finance at the International Vaccine Access Center. His research focuses on incorporating equity into economic evaluations of public health interventions, evaluating the economic benefits of vaccines and public health interventions in low and middle income countries, understanding individual preferences over health and healthy behavior, and designing and evaluating mechanisms for sustainable health financing for countries undergoing donor transition. Today he'll be giving us a talk on measuring inequity in vaccine coverage and cost of illness, which is the topic of the VERSE toolkit, which he'll explain. And I think the plan is for Dr. Patenaude to give his talk in sort of 30 to 40 minutes, and then we'll have an open question and answer period, which I'll try and moderate. And it will be useful if you participants can use the hand raising function of Zoom or type in the chat that they have a question, and then I'll sort of shepherd those to Dr. Patenaude. All right. Without further ado, go ahead. Thank you.
Great. So hopefully everyone can see my screen and hear me. Okay, good. So thanks, Steve, and thanks for having me to present. I'll be presenting on measuring inequity in vaccination coverage and cost of illness, and introduction to the VERSE toolkit. And I'll explain a bit what VERSE is and what that means in this presentation. So to give an overview of what the VERSE project is, VERSE is an acronym that stands for Vaccine Economics Research for Sustainability and Equity. It's a Bill and Melinda Gates funded project housed out of the International Vaccine Access Center in the Department of International Health at Johns Hopkins. And the primary goal of this study is to provide countries with robust evidence on the economic and equity implications of their immunization financing and delivery strategies, and has two primary components, well, really three primary components to overlap a bit, but the ones that we'll primarily discuss today are the vaccine equity assessment methodology and toolkits, as well as some country case study applications of both the return on investment and economic impact tool, as well as the vaccine equity assessment toolkit. So for the vaccine equity component of this work, the goals are really to develop a model and a tool for countries to use to make standardized equity assessments of vaccination coverage that are comparable and trackable over time, to allow for modeling of equity efficiency or equity coverage trade-offs, and just to compare different entities on the attainment of both dimensions of equity and coverage. And then to pilot this work in 2 to 4 countries and develop application case studies of how this toolkit can be used to answer different types of questions, whether that's with routine data or primary data, and then going forward to track sort of what the policy use and the application of that work has been downstream, to get an idea of how this information can continue to be useful for policy and decision makers. So what are we doing in this equity toolkit? So first I'm going to talk about what we're measuring, and then I'm going to talk about how we're measuring it, and then move into application. So equity in what? The dashboard and toolkit that is under development through the VERSE project examines equity over several key outcomes that are particularly relevant to vaccines, which include programmatic equity, or what we're classifying as programmatic equity. And this includes vaccination coverage. So the typical metric is just % of the population that's accessed the vaccine by the appropriate age in the national immunization schedule. And this can be done over vaccines individually rolled out in a specific setting, or sort of a fully immunized or zero dose indicator to measure the equity in attainment or in prevalence of that specific outcome. The second topic to measure equity over, which our tool is adapted for, is vaccine preventable and disease-related out-of-pocket expenditure or cost of illness benefits related to the specific setting and vaccine in question. And we'll talk about how different types of data sources later on are amenable to these different types of outcomes. But one of the benefits of the sort of verse approach to measuring equity is that these results are comparable across these different outcomes. So you could compare sort of the equity in actual access to vaccines compared with the equity in out-of-pocket expenditure that access affords. So it's a good way to think about, in a more universal healthcare style focus among multiple dimensions, how different actors are performing on equity. And with that, the last metric that's feasible to assess using this toolkit is health outcomes attained. So these can be DALYs averted or QALYs gained or lives saved due to the vaccine, and how sort of that modeling efforts to model the impact can be incorporated to assess the equity and health outcomes. So a lot of the foundations of this work was to address some of the shortcomings in the existing toolkit. So there's a lot of useful data out there on equity. The WHO HEAT toolkit, the Health Equity Assessment Toolkit, is a particularly useful source that allows you to pull data from different types of public studies like the DHS or the MICS, and examine different types of inequalities over time using different indicators for different outcomes. And so you can see here a snapshot of what that tool sort of allows one to do: compare equity and across economic status or education for different years on a specific indicator. So here's full immunization coverage. What the VERSE tool is attempting to do is address this idea of intersectionality in the concept of equity, and that there are multiple different factors that are contributing to overall inequality. So looking at it over any one dimension could be misleading. And it can also be problematic when trying to track overall progress towards equity. For example, if you have sex-based as well as socioeconomic-based inequality, and they're not perfectly correlated, and attempt to address one dimension without the other may have differential impacts on overall equity, and it's difficult to say what that would be. So our attempts here are to create a metric that takes into account the relative contribution of each of these dimensions in order to track progress towards equity more holistically. But in that same light, it's compatible with sort of the same data sets and output types that are used in these existing toolkits. So again, some of the goals of this project across the dimensions and outcomes that I just shared are to show multivariate equity over a number of different dimensions, to pit this against efficiency indicators, including coverage or cost per dose, at a subnational level, to compare how different regions within a country or how different countries are performing on both planes, and to allow for both health and economic outcomes data permitting, so including that cost of illness data where we have some representative surveys on that, or out-of-pocket expenditure. So now I'm going to move a bit into the specific methodology of our sort of composite equity indicator, and then move into some case study applications of how that's being applied. So the composite equity indicator that the VERSE team has been working to develop utilizes an approach that was first sort of outlined in this Barbosa and Cookson paper in 2019, and Richard Cookson is actually a member of our advisory committee for this project, which tries to isolate fair and unfair determinants of a specific outcome and create a ranking criteria based upon that. So that paper takes a look at the binary case, which is adaptable for the vaccine space, to coverage outcomes, yes or no, a child received a vaccine. And we also sort of addressed the multi-level aspects of that, having an outcome that is categorical, as well as having an outcome that is continuous for the cost of illness sort of outcomes. But for the vaccine, what we do in a standardized way is take a look at what types of data are available routinely in surveys that collect information on vaccination status, as well as other sociodemographic indicators. which of those contribute meaningfully to vaccination status and which ones are measured in a comparable way across settings so that there can be a degree of standardization in the ranking process. And so what we've come from, discussions with people in various settings, our partner countries in India, Uganda, Nigeria, Bangladesh, and China, as well as through an analysis of some survey data sets that have been available and identified that can routinely collect information over time on this type of information, is that several things are collected fairly routinely across data that are relevant to vaccination status. And these include sort of socioeconomic status, typically measured by a wealth quintile or a wealth index from the DHS, urban or rural designation of residence where the individual who's vaccinated resides, the politically relevant geographic subdivision. So this could be the state or the region or the district, depending on what is of interest to policymakers for a comparative dimension. We typically advise that this be something that is health system relevant. So state, for example, is particularly useful in settings like India or Nigeria, where there are significant state centered health systems. The sex of the vaccine recipient, male or female, maternal education level, and the health insurance coverage, with the acknowledgement that in other settings beyond the base, this is what's included in the base case. Beyond the base case, there are needs to address very specific things. For example, caste in India has been identified as important for that setting as part of the ranking mechanism, as well as potentially religion or ethnic group. These things aren't typically recorded in a standardized way across surveys, so it's difficult for the general base case to incorporate all of those nuances, but for specific adaptations of this toolkit towards primary data or to specific questions within a country, those can certainly be added to the sort of unfair drivers of inequity, so long as data is available on that. And then fair drivers of inequity. So there are a number of different ways to think about what should be fairly driving inequality for the base case in our model. And for vaccination, we take the assumption that the only fair driver of inequality and access should be whether or not the child is underage by the national immunization schedule to have received that specific vaccine at the time they were recorded as being part of the survey. Other things we're going to acknowledge are unfair. Other things that one might consider putting in these fair drivers are things like immunocompromised or unable for allergy reasons or other reasons to be vaccinated. That data typically doesn't exist, but in settings where you're doing this alongside perhaps an RCT, those could be incorporated as fair drivers to receipt and access to vaccines and can be incorporated into the model to sort of net those effects out. And for economic outcomes, so for cost of illness and out-of-pocket expenditure, specifically, one of the other fair drivers of inequality in those outcomes that is sort of a requirement of the base case is whether or not you're receiving care at a clinic versus a higher level hospital, and whether or not that facility is public or private. And we classify public and private as sort of a preference-based indicator that is not an unfair driver, but a choice-based driver of whether or not you're incurring out-of-pocket expenditure. Another facet of the toolkit is the ability, and we'll showcase this with an example later on, is to address each equity dimension separately with some more traditional indicators so that this can be compared across studies that have been done previously. So just to give a rough picture of what this looks like, what we're doing is we're creating a model that takes these different fair and unfair drivers of potential inequality and vaccination status, along with the health status, and creating an indicator that in the literature is typically referred to as direct unfairness, in which we call direct unfairness in vaccine access, which takes into account the ability for unfair variables that we've classified on the previous page to influence your outcomes, holding the fair determinants of healthcare at reference levels. So this is the variation in outcome access, so in vaccination status, that's driven unfairly by the different indicators that we showed in that previous. So in a way, this creates a metric that takes into account the multiple different dimensions that someone could possibly possess to prevent them from accessing vaccination in a certain setting unfairly, and calculating them into an indicator. And that indicator is based upon a logistic regression, which takes those different fair and unfair outputs, holds the fair ones at reference levels, and models the variation due to unfair determinants, in terms of the outcome, and then predicts your values based on allowing those unfair determinants to vary as they do in the data, holding the fair things at reference levels. So this should look familiar to some of you who are, more used to doing this type of thing mathematically. This is essentially for the binary outcomes, producing a propensity score for unfair deprivation and access. And so what we want out of this is not something that the values are actually like super specific. We don't care what the individual's actual predicted value is in and of a sense, but we do care about their relative ranking towards one another across this. Because you'll see what we're doing with this is not, concretely, absolutely measuring the impact of unfair characteristics, but ranking how likely people are to be disadvantaged based on those unfair characteristics. And so what we do to measure equity utilizing this approach is to take that sort of ranking criteria of unfair deprivation and utilize that in the context of a traditional sort of approach to measuring inequity, which is the concentration index or the absolute equity gap and the outcome, where instead of, under the traditional approach to concentration indices using socioeconomic status as your ranking variable, so ranking people from most to least advantage in terms of wealth index, for example, we use this composite deprivation index to rank people. So we're ranking people from sort of most unfairly likely to access treatments to least unfairly likely to access vaccination. And in doing so, we're able to take a look at sort of this multidimensional inequality by running our equity analysis over that rather than just socioeconomic status. So the approach is sort of compatible with a number of different types of indicators that are routinely available: the Wagstaff style direct concentration index, the Ehrger's adjusted concentration index, the horizontal inequality index, and these are the different types of specifications for those different things, as well as the absolute equity gap. Our sort of preferred approach is to just take the traditional concentration index, which for those who are familiar with the Gini-Coefficient is the same sort of Gini framework for dealing with inequality, where instead of ranking people by income on the x-axis, we're ranking people by composite disadvantage and taking a look at how the inequality in coverage as a share relates across this curve. So we can objectively say that we don't want any of these unfair factors to be influencing vaccination outcomes. So the ideal would be to see a population that falls on this line of perfect equity and have your score be 0. But obviously we're seeing these driving different things in different settings. So you're going to have some positive value. That value is standardized because the area is bounded by 1. So 100% and 100% scaled to 1 and 1. So you get a metric that's comparable and trackable over time and standardized between settings in order to measure sort of how people are ranked and how people are doing on equity in vaccine coverage across these outcomes. And it takes into account automatically, because of the ranking criteria, all of these different dimensions of equity. So it's a holistic look at inequality and access in a way that people are familiar with. We also compute for each of the outcomes that one might want, so specific vaccines, the health equity things, the slope index, relative index, concentration index, really all of the things that are included in the HEAT toolkit can also be pulled out of our tool. So for comparison with previous studies, if you don't just want to use this composite equity metric, but also want to take a look at the more traditional approaches to measuring equity on a specific dimension. And what this does sort of differently, again, with the ranking criteria, from just decomposing a regular index as decompositions of concentration indices that have been done in the past focus on decomposing socioeconomic inequality into its component parts. But if you have a dimension that's not fully correlated with socioeconomic equity, you're only going to be capturing the proportions of that dimension that are correlated. So gender-based inequity may or may not be fully correlated with socioeconomic based inequity. And if you're just decomposing socioeconomic inequality and trying to decompose the gender component, you're not going to be capturing that full picture of gender equity, which is something that is a little more explicit in our toolkit. So because it's a traditional metric, it's subject to the same types of decomposition methodologies that can be used on these other types of inequality metrics. So the OAHA blinder types of procedures where you can run a regression-based decomposition analysis and break the inequality back into its component parts. So what we're able to do with this composite index is then break down how much of that composite index is due to each of the dimensions. So this is a more holistic type of equity breakdown rather than just a decomposition on a socioeconomic inequity indicator. And so this helps to inform the relative contributions of each of those different dimensions towards the observed inequities in the outcome. And we find that this is particularly useful for getting an understanding of the relative contributions of each of these dimensions, as well as to sort of inform policymakers on what the key contributors are and how to think about addressing some of those contributors. Finally, we have this sort of equity efficiency or equity coverage plane that we can, for a snapshot, take a look at how regions compare on coverage and this equity indicator with one another. And also if there's multiple years of data from multiple surveys to sort of center a baseline year and see how different regions or different countries have moved on the equity efficiency plane, ideally in this sort of northeast sort of component, but on a win-win, increasing equity and efficiency, but just to see how that plays out over time to give an idea of how performance has been for resource tracking and for tracking for equity related interventions. So just to show what this looks like in the dashboard, I talked about this. This is a mock-up. Right now we have sort of our code that's in a GitHub where you can run it. We're working with countries to sort of populate this now. Our goal is to have a Shiny app that comes out early next year where individuals can interact directly with the Shiny app to get outputs like this. So the goal is to be able to select different types of vaccines that are available. The data set as well, specifying whether you want to upload a data set or whether or not, and we have guidelines for formatting those data sets, or whether or not you want to utilize a publicly available data set such as the DHS or the mix, which our tool is compatible and can pull to see what's going on. So you could take a look. This is an example using DTP1, coverage and wealth quintile, and sort of comparing two regions in Bangladesh on performance and sort of taking a look at the component that wealth quintile plays towards overall inequality that's observed in vaccination status of DTP1. You get the equity efficiency plane as I showcased for different regions. And you can do this over different vaccines. And here's the over time sort of for countries that have multiple years of data. And then what the tool can also do is pre-populate sort of a summary table that takes the indicators for the different things that are specified. So here's an example with the slope index or relative gap, gives the value and gives sort of a one-line interpretation of what that means so that there's no confusion over the interpretation of those results. Defines exactly what that index is and what it's doing with a reference to the mathematical equation in case that's of interest. It's in the background, so it exists. But not taking up space, and can pre-print these sort of one-pagers, which give a lot of visuals and quick one-line summaries right here of what the interpretation of this is, and some information on the specific interpretation of the outputs from this. And so these can be shared at meetings with stakeholders to just get an equity snapshot of what's going on at any given time with a specific piece of data. And again, this exists right now as sort of an R function that you can specify the factors that you want included. If you just say base case, it includes all of the ones I discussed. Which vaccines you're interested in doing, including indicators for 0 dose, fully immunized, or actual completed the immunization schedule for those who are of age to have completed the immunization schedule. What you want your data to be, if you want your geographic subunit to be the state, the country that you're interested in or countries. If you want mapping turned on or off, we can link directly with shape files provided by the DHS and the district level data to generate heat maps of inequality, which I'll show in a minute. And then the results get stored. So these are the types of things that would be required as inputs. It's pretty straightforward. Those are the only things that need to be toggled if you want to use this tool for the DHS. Or mixed data sets. If you want to use it for specific data, we can work with your team to provide guidance on how to format that data set, as well as adjustments that may be needed for different types of questions. And I'll get into some of the questions that we're working with partners to answer in just a minute. So some of the case studies that we're doing, just to give an idea of how this tool may be used and where we're sort of working with partners right now to identify use cases for this. We're working in 6 different settings: Bangladesh, China, India, Nigeria, Uganda, and some quick support for Zambia. The first case study in India, the goal is to take a look at routine immunization coverage, but also particularly zero-dose inequality, and to assess the level and drivers of inequality in zero-dose status. So never having received a single routine dose of DTP, MCV, or OPV by 24 months of age, utilizing the National Family Health Survey 4th round data. We're hoping to update this with the new data, but I don't think that's going to be the case right now. So we're utilizing that survey from 2015, 2016. And sort of what we get as a snapshot output is you can get a composite equity metric in zero dose. The composite equity metric that we report is actually an absolute equity gap derived from the concentration index. So it's a little more interpretable to policymakers. You can get the direct index if you want, but how this is that the most disadvantaged quintile of the population would need to zero dose status would need to be decreased by 10.5% to reach the levels of the most advantaged quintile. And you can get this for each vaccination separately as well. So just giving an idea of the degree of inequality that we're seeing across this disadvantage. And then what the drivers of that inequality are. So we see that for zero dose status in India, maternal education is the leading contributor, unfair contributor, at 31.4%, followed by socioeconomic status at 16%, health insurance coverage 17%. We're still not explaining the full amount of variation. And what's interesting in this decomposition, the decomposition is really sort of over the unfair drivers. We're able to incorporate also into this diagram, because I think it's interesting, sort of people who are not zero dose, because we're classifying zero dose as being 24 months of age and still not having received any doses. But these children who are underage are people who would be qualified as zero dose because they haven't received anything yet. They just haven't met the criteria for this sort of formal definition of zero dose. And that, sort of looking at this down the pipeline, those kids may be contributing a lot to future inequality. So just 30% of the overall fair and unfair assessment of inequality, we're getting a lot of people who sort of are not yet contributing to unfair inequality, but maybe down the pipeline. And also for India, we could take a look at how these metrics compare across the spectrum of vaccines. And you see that one common trend that we see is that inequality increases as you move away from birth doses. So whether or not it's DTP, OPV, MCV, you see that as you move further away from birth doses, inequality tends to increase. And here are some of the illustrative heat maps for India, where we can take a look at prevalence and equity in terms of how zero dose looks. You can see here that they're relatively overlapping in terms of regions with high prevalence of zero dose have high inequality and zero dose status, particularly because we're doing a really good job at figuring out that these determinants actually contribute to capturing variation in overall zero dose status, which is why there's so much overlap. But there's some differences in the rankings. You can see that, for instance, regions over here quite high or low in zero dose prevalence, but there's a significant degree of inequality, meaning that this is concentrated among the most compositely disadvantaged in that setting, where in other states it may be spread more apart. And for the equity efficiency plane, we use DTP1 coverage here as an example of sort of a first routine immunization that one is likely to receive after birth doses of BCG, to get an idea of how different states are performing on equity and efficiency in rolling out a vaccine. So you can see how this is useful is sort of to compare states that are at similar levels of efficiency and coverage and map out how they're doing on equity dimensions. For example, trying to explain and do more of a deep dive to figure out why Manipur is performing significantly lower in terms of equity than, for example, Karnataka, but achieving similar levels of coverage. So this is just a good way to map progress. One thing that is good is that we're seeing a general upward trend here in terms of coverage and vaccine efficiency, which one may not expect. This isn't true for all vaccines. You get a different story when you look at things like HPV, for example. But largely for the pediatric vaccines, we are seeing relatively cohesive story that equity and efficiency are roughly moving in the same direction. And here's just more illustrative. We can get these heat maps for all different vaccines across the cascade and the relative contributions of the determinants for each different vaccine, and as well as these planes for different vaccines if they're useful. And so you see that there's more discrepancy again in equity efficiency attainment, moving in that sort of cohesive upward northeast movement as you move further away from birth doses. And again, here's some other different outcomes. So fully immunized heat maps versus 0 dose versus DTP1. And just showcasing these lines that are useful for interpreting this, trying to figure out how different performers who are achieving similar levels of coverage are doing on equity, and then why that might be. So this provides some evidence to warrant sort of a deep dive investigation and to inform sort of what states or what areas to potentially target for equity improvement programs. Our second case study is in Bangladesh, and this is different. So we're not utilizing routine data for this one. We're collecting primary data with our partners at the International Center for Diarrheal Disease Research. And to assess the level and drivers of inequity and epi-schedule vaccination status and cost of illness and out-of-pocket expenditure due to vaccine preventable illness between urban, rural, and urban slum settings. So urban slum settings in a lot of the routine data in Bangladesh are underrepresented. So we're doing sort of a household survey as well as a facility-based survey to try and do a better job at capturing residents in those areas and their experience with vaccine preventable disease and vaccination and sort of the economic consequences of vaccine preventable illness in those settings. So field work for that is currently underway. We're collecting primary data. We've worked with the team there to format data in a way that's conducive to running the VERSE methodology on, and then we'll be able to take a look at sort of what the snapshot is of inequality and drivers of inequality are compositely in that setting to inform sort of how to better target resources to obtain inequality, as well as to provide a baseline measure to track progress towards reducing multidimensional inequality over time. And you can see this will be posted after the, I'm not going to get into for a lot of detail on this, but you can see some of the data that we've collected in these settings under the previous study that we've worked on, the Decade of Vaccine Economics study, where we started collecting data on sort of socioeconomic disparities in outcomes and in out-of-pocket expenditure within Bangladesh and Uganda, where we worked under the previous study that helped inform how we're applying and utilizing these types of assessments in the VERSE study. And so these are available for you all to look at after the call. The third case study that we're doing is in China. And the question here is to assess the level and drivers of inequity in non-national immunization program vaccines and their coverage. So these are Hib, pneumococcal, PCV, rotavirus, varicella, influenza, and HPV vaccines. So utilizing the multidimensional inequity indicator and the decomposition procedure to take a look at what the drivers, what the contributors are towards inequality in those non-immunization program vaccines, what it looks like across regions and access, and to also use as a baseline for tracking what inclusion of those vaccines into the national immunization program may attain. So this is sort of a baseline snapshot, getting an idea of what things look like, trying to figure out which vaccines to prioritize for from an equity standpoint, including in the immunization program, and then to track progress on how that inclusion works in terms of equity reduction or inequity reduction. And so we're partnering with Peking University there, who's working with the Chinese CDC to take a look at this type of data. Which will come from survey data that has been collected over time by Peking University. In case study 4 in Nigeria, similar to that in India, utilizing the DHS for Nigeria and multiple rounds of DHSs to showcase the improvements or changes in equity over time for routine epi-schedule vaccination. And so we get, similar types of outputs that we have for fully immunized for all epi vaccines, both fully immunized for age and completing the immunization schedule. And what the breakdown of that looks like. You see again that, unlike India, where state wasn't a huge contributor, state is actually the second largest contributor towards full immunization status, even including all of these other things. In Nigeria, and maternal education is still like a huge component of the drivers of overall observed inequality and actually becoming fully immunized for age. And again, you can see the same pattern across the cascade, inequality increasing as you move further away from birth doses, but very different levels across vaccines and significantly higher than what we were observing in India. And again, since these are standardized and the ranking approach is the same, these are comparable metrics both across settings and within settings across vaccines. And you can see some of the similar heat maps for Nigeria that we developed for India that sort of help to paint a picture of this story and how you move across the DTP vaccinations as you move further away from birth doses, and what that means both in prevalence of the access as well as in the equity within that region, and measuring the equity efficiency maps. And so our last case study that I'll discuss here quickly has to do again with utilizing or routinely collected data, but not a DHS, to track the progress of a specific vaccine. So in Uganda, one of the things that we're working with Makerere University, as well as partners within the Ministry of Health in Uganda, is tracking the level of equity and drivers of inequity in rotavirus vaccine coverage and out-of-pocket expenditure related to diarrheal disease following the introduction of rotavirus vaccine in 2018. So we're working on combining data on the rotavirus vaccine rollout with the Uganda National Living Standards surveys to get an idea of how these two, the economic and the health factors have been moving together, how inequality and access has changed throughout the rollout, and how we can use these types of routinely collected data sources and link data together where applicable to monitor rollout of new vaccines in a country. So this is a use case particularly aimed at sort of programmatic tracking of inequality and rollout in new vaccines. So this is for rotavirus. We think that this can be used equally well for coronavirus vaccination tracking. Obviously, there are some different things one might want to consider in different settings for coronavirus vaccination, particularly related to the age. But one nice thing, taking into context what we're doing here and what could be done for COVID, is that for COVID vaccine, there are a number of different phases where vaccines are available to different individuals with different characteristics, so pre-existing conditions, high risk jobs, different age prioritization and everything. And what's nice about the VERSE indicator is those things can be directly accounted for in the fair determinants to inequality to access. So like, for instance, if you were just to do sort of gender-based inequality and not take into all those accounts, you'd have to do multiple analysis over multiple of those different things to measure the inequality at each tranche of the rollout. Whereas if we have time data and we have the different characteristics, we can incorporate all of that into the ranking procedure and net out all of that fair variation and inequality and access, and just focus on what's been driving from an unfair perspective, inequality and access. So in a way, this is very, very applicable to monitoring the rollout of a vaccine, where you have sort of a whole bunch of different potential fair determinants for not accessing at a specific time. And again, for the purposes of those who are interested later on to take a look at what we've done previously in Uganda, you can see that we've also collected a lot of information on diarrheal disease, measles, and pneumococcal, both how people are presenting, whether or not they're vaccinated, out-of-pocket expenditures, both direct and indirect, to get an idea of what the picture looks like. So we have collected in the past nationally representative data on cost of illness in Uganda and Bangladesh that we're using with the tool. We have sort of standardized templates for countries that are interested in collecting cost of illness data that could then be used to track equity and cost of illness later on, because we acknowledge that a lot of this isn't routinely collected in survey data. Often out-of-pocket expenditure is, but that may not be linked directly to vaccine preventable illness. So if there's a need for a deep dive or a desire for a deep dive in this, we also have tools not tools, but like surveys, pre-formatted questions that can be applicable to different settings to assess cost of illness in order to help countries be able to create and incorporate those into existing surveys to collect data if they're interested in answering these specific questions related to vaccines. And then in Zambia, I'm not going to go too far into this, but we're doing this same thing as in Nigeria and India, taking a look at the drivers of GTP1 and MCV1 specifically, and comparing the differences between what we see for MCV1, which is delivered via campaign in a number of settings, versus zero dose in general and DTP1 coverage. So just to summarize sort of what the policy applications of this are, and just talk a little bit about engaging with our team if you're interested. Some of the applications are that we envision are to hold programs accountable to targets and create sort of standardized ways of tracking equity in a multidimensional way to use as a target and monitor progress towards achieving inequality goals over time. To identify changes in the contributors to inequality across different types of vaccines and outcomes and over time, to assess the equity coverage trade-offs and determine sort of lagging regions or districts on one or both dimensions to target programs to improving attainment in those areas, to demonstrate empirically to the extent to which reductions in one dimension of inequality or a program that's meant to target a specific dimension of inequality has an effect on composite inequality and the outcomes that one cares about, and to combine the data on economic outcomes and coverage outcomes, utilizing a standardized methodology so that these can be comparable. Perhaps there's a low degree of inequality in access, but a very high degree in inequality in sort of the cost of illness associated with access or not accessing vaccines. And that story can be interesting to examine, particularly in the context of the multiple dimensions of universal health coverage. So expanding coverage, expanding financial risk protection. This sort of allows you to track equity in both of those dimensions in a comparable way. And sort of moving forward, we hope that this can be expanded beyond the vaccine space. And we're currently working on also testing applications towards other pediatric and maternal health issues with this type of indicator. So antenatal care access, for example, so that we can think about how one might take a package of interventions and utilize this approach to develop sort of an equity indicator for primary healthcare access, or for sort of universal health coverage attainment equity overall, trying to bring this into the bigger picture for health systems purposes rather than just focusing on sort of the siloed area of vaccines. And then I just will quickly, with like the last 2 minutes, highlight the second portion of the VERSE project, which isn't the main discussion of the point of this meeting, but just to highlight some of the other things we're doing is we're also developing a web-based toolkit, a Shiny toolkit to track return on investment for introducing new vaccines or existing vaccines. And so again, we've done work through the decade of vaccine economics and quantifying the return on investment for vaccines covered by Gavi in their investment case. And there's, we've published data on this in the past, but now we're working with some countries in adapting the multi-country model to be more country specific, be able to take country specific economic information and utilize that in conjunction with country specific epidemiologic information to create a tool that allows decision makers to develop their own investment cases. So we've been working with folks in Ecuador at the Ministry of Health and the Catholic University of Ecuador to identify the return on investment for PCV10 in Ecuador, utilizing some specific nationally representative randomized control trial data that was conducted on the health impact of PCV10 vaccine in Ecuador, alongside economic information that was compiled through the university there and the Ministry of Health in Ecuador to create an investment case. And so that has been conducted. You can see that we were able to create both national and subnational return on investments, and to showcase how that has changed between introduction year and future, how it's projected to look going into the future, utilizing data that's been available. And so this can help provide an investment case for introducing a new vaccine or maintaining investments in a vaccine over time. And also sort of rationalizing, if there's negative ROI in an introduction year, how that may be forecast to change later on. And so again, we're working on creating sort of standardized templates to allow data to be formatted and upload into a web-based application that you can then get ROI estimates through this standardized methodological approach that we've applied in other settings. So this can be a bit more useful to advocates and stakeholders in specific settings when thinking about the investment case for either new vaccines or continued investment in existing vaccines. Just to highlight members of the VERSE team advisory committee, and thanks to all of their inputs on this so far. And with that, I will end my presentation and open this all up for questions.
Thanks a lot, Brian. I just invite the audience, if you wanted to ask a question, just go ahead and raise your hand, your Zoom hand, or type in the chat to let me know that, and I'll call on you. And while you're thinking about your questions, I can kick us off with one. So I wanted to, thanks for the presentation, very interesting. I'm wondering how you, or if you've thought about disease risk variation in the population, because, and whether you would consider that potentially as a fair driver or not. But it seems to me that, if we were looking at it from a return on investment standpoint or value for money standpoint, and even in the COVID case that you illustrated, it makes sense to vaccinate, the most at risk first. And one could even, through an equity lens, sort of think that people who are at the highest risk deserve a priority. And so it could, and it seems like disease risk is something that's right now missing from the framework. And so it does seem like it would be something that could be an explanatory variable in the relationship between inequity in coverage and inequity related to cost of illness, potentially, because people who are more likely to get the disease are going to more likely have expenses for the disease. But beyond that, it seems disease risks in and of itself, because of the health impacts, could be an important thing to include. Over.
Yeah, so I completely agree. And I think in the context of particularly adult vaccines, that's extremely important. And so that can be accounted for in the sort of, early on, I set up the framework for how we think about the ranking variable. One of those was preference-based, and another was, fair determinants. And disease risk can fall in either one of those and be, assessed along that way. And I kind of highlighted not really necessarily risk, more like a country priority way that you might incorporate the sort of COVID considerations into the model. But for any other vaccines in the background, so like if you're doing this for influenza vaccine, for example, disease risk is certainly something one might consider as a fair sort of preference-based determinant of that. And insofar as we have a way to measure that, these tools require individual level data to some extent. So we would need to have a standardized methodology for taking the different determinants that we have data on and proxying risk and accounting for that in a way that's sort of, not inducing bias in the equation, but there are a number of ways that that's feasible to do and should be done, particularly for things that have sort of, our goal is not to reach 100%. Our goal is to vaccinate and reach those who are most vulnerable or at risk.
Thanks. Kaja?
Yeah, sure. Thanks, Stephen, and thanks, Brian, for the nice work and presentation. I was just kind of wondering with respect to, as long as the coverage is below the herd immunity threshold, there's always going to be enhanced risk of outbreaks taking place. So in essence, if the coverage is lower than the herd immunity threshold, but it is much more equitably distributed, still the population is vulnerable for outbreaks compared to a scenario where the coverage is much higher than the herd immunity threshold, even though there may be pockets of much higher inequities. So I just kind of want to know your thoughts on shouldn't the primary focus should be to drive up the coverage above the herd immunity threshold? Yeah. Thank you.
Yeah, so here's a great example. Let's look at this fully immunized for AIDS. This is not a specific vaccine. I wonder if I have a specific vaccine in here. Yeah, so let's take a look at, well, let's just take a look at DTP1 vaccination in Nigeria for a second and talk about this. So this is one of the things that I think the equity efficiency plan is useful for, is talking about, when it makes sense to intervene on equity improvement situations and when it may make more sense to deal with efficiency or coverage improvement situations. So let's take a look at, where we are if you're below, a certain coverage threshold in an area, and maybe combining this disease burden data. When your country's down here, it's probably more important to move them up than it is to move them towards equitable coverage. Whereas if we're in a situation like we see in India, where we're already at very high levels of coverage, like very few states or regions falling below 80 or 90%, then it's about talking about moving to the right and upwards and getting those, marginal zero dose kids who haven't get it, how we're reaching them, but also improving the equity and access. So between why is a state that is achieving almost 90% coverage significantly less equitably distributed than another. And so you can kind of see areas where it makes sense to intervene on one or other of those dimensions from that output. We're not making a, sort of assessment about when that's appropriate or not, but we're hoping that some of our visualizations can help to provide context for when and where to, make that call for policymakers in terms of where people are at in terms of their vaccination and whether or not it makes sense to deal with an equity improving intervention at that time.
Sounds good. Thank you.
Mm-hmm.
I suppose in some sense, to Kaja's point, it makes in idea if the people if people were equally mixed in terms of how they interact and transmit disease, then it wouldn't then the goal of reaching herd immunity, you could reach 90% coverage, and it doesn't really matter if that's less equitable or more equitable, but if people are sort of physically located and interacting in a way that it tends to be, correlated with their strata, like, low SES people interact more with low SES people, then in that case, even if you have overall coverages that are approaching herd immunity, you might be way below that for certain groups, and those groups may be correlated with the dimensions of equity that you care about. So it's tricky, it's interesting. Any other questions from the audience? I wanted to ask one more then, I guess. So I'll take the prerogative. So it looked like in most of the, I haven't seen a lot of the results, but in what you showed, it looked like maternal education was frequently showing up as one of the most important drivers. And I was wondering if you are seeing patterns like that are really consistent across settings and across vaccines, that maternal education is always more important than wealth, or these kinds of patterns, and if that's the, yeah. So I guess, and the other question related to that is, when you find these countries that have similar or settings that, like within a country, that have similar coverage but score differently on the equity dimension, it seems like there's a set of factors that might explain that, like places, like it could be that the difference between the two places is one requires user fees for vaccine and the other doesn't. And so, and in that situation, I guess you would expect wealth or income to be more of a driver than maternal education, and that sort of thing. So there seems to be some relation to these drivers that you have and then actual structural policy issues, right?
Yeah, we definitely agree that there's a relationship between the two. We're trying to, make the best use of what's measured routinely in a consistent way, and utilizing this as more of exactly as you said, sort of just getting an idea if you're at the same levels and you're performing differently, what those driving dimensions are, and then taking a look and doing a deep dive and figuring out why that might be. Our tool is not going to tell you why that might be. It's just not designed to do that, but it's meant to help you, drive you in the direction of what the areas are to be considered, and sort of identifying those structural barriers that manifest themselves and that are actually actionable on those dimensions. And back to your trends, we do see, not always, but I mean, we've been seeing a lot of the settings that we've started working in, maternal education really being a driver. Like from the evidence that we have from China, we're not seeing that as much there. But we are seeing it in a number of things. We're in the process of trying to apply this to everybody who has a fourth round of a DHS, and just trying to get a better idea of what that looks like over the countries, because we've only run this in these 6 so far. But we are seeing that maternal education, contrary to our expectation, has been a leading cause above wealth index, above state. But in areas where we expect, we're seeing more heavy influence of geographic location than in others, which is also interesting. So you see that in Nigeria, with states having a huge play in the inequality, even taking into account sort of socioeconomic status and the other variables that we do.
And then it's sort of supposed to serve as a diagnostic, and then you'd have to go in and say, well, what are the differences between the states in terms of maybe their health is a lower priority, they spend less of their government funds on health or something else, right, to figure out why that is.
Yep, this is a diagnostic and then an M&E tool, so that then if there's an identified problem and solution, one can collect follow-up data afterwards, use the same indicator, and track did things get better.
Do you, I'm not seeing any other hands, so I'll try and squeeze in one more. That is, you focused heavily on the 0 dose coverage metric. And I know that there's the policy community, there's a lot of priority on that. And I guess I wasn't quite clear on the other alternative metrics. It seemed like one of them was the number of people who had a completed schedule, right? But do you have measures that are sort of continuous measures in terms of like the % of this scheduled that's complete or something like that?
Well, so fully immunized for age, which I presented for number 1, is not completed. We have completed the immunization schedule, limited to those who are like of age to have completed, but fully immunized for age is like anybody. So there's no wrong, like if you just got the birth dose and you're just over birth dose stage, but not yet eligible for MCV1, you're considered fully immunized for age. Okay. So that one does get at that. It is binary, but it does get at that question of how you are on that progress spectrum.
Okay, I see. Well, thank you very much, Brian, and thanks everyone for attending. You'll notice in the chat that we posted the information for the next webinar, which we encourage you to join, and any feedback that you all have on this webinar series, we're glad to take it in and try and make it better. But I guess maybe a virtual round of applause for Brian. Thank you very much for doing this. And I really appreciate it.
Yeah, thanks everyone for attending. And if you're interested, feel free to reach out. You can share information and I'll circulate the slides.
Really interesting stuff. Thanks a lot.